Good morning, everyone. I'm excited to welcome you to today's presentation. Today, we'll be exploring Zollinger-Ellison Syndrome. On this first slide, you'll see the title and a brief overview. We'll discuss what this disorder is, its causes, and its effects on the body. So let's get started and dive into understanding this fascinating condition. Let's take a closer look at Zollinger-Ellison Syndrome, also known as gastrinoma. The most common site for G cells which produce gastrin is the stomach. However, when it comes to where gastrinomas, the tumors responsible for this condition, are typically found, the most frequent locations are the duodenum, followed by the pancreas, and then the stomach. Now, to connect this with clinical practice, imagine a patient, a woman between 30 and 50 years old, who's been experiencing recurrent epigastric pain over a long period. She's been using PPIs or proton pump inhibitors to manage her symptoms, but she also develops diarrhea. These signs and symptoms, especially in someone with long-term PPI use, should raise suspicion for Zollinger-Ellison syndrome. Understanding these key points helps us recognize the importance of considering gastrinoma in patients with persistent gastric symptoms and atypical responses to standard treatments. It highlights the significance of location and clinical presentation in diagnosing this syndrome accurately. Let's take a closer look at the causes of diarrhea, starting with gastric hypersecretion. When the stomach secretes too much acid, it leads to an acidic pH in the duodenum. This highly acidic environment can inactivate pancreatic enzymes, which are crucial for digestion. Without these enzymes functioning properly, sugars from our food aren't absorbed effectively, leading to unabsorbed sugars in the intestine. This unabsorbed sugar then draws water into the gut, resulting in diarrhea. Additionally, the excess acid can cause mucosal damage in the duodenum, further aggravating symptoms. Now, this process is often associated with a condition called MEN type 1, which is a genetic syndrome. To remember the key features of MEN 1, we use the mnemonic PPP: pituitary, parathyroid, and pancreas. Starting with the pituitary gland, a common tumor here is a prolactinoma, which can cause hormonal imbalances. The parathyroid glands often develop adenomas, leading to increased calcium levels in the blood, hypercalcemia, which can stimulate acid secretion in the stomach. Then, in the pancreas, adenomas can cause Zollinger-Ellison syndrome, characterized by excessive gastrin production that stimulates acid secretion even more. There are also other clues that can point us toward this diagnosis. For example, a family history of kidney stones or a personal history of kidney stones is significant, since hypercalcemia can predispose to stones. Finally, signs like liver metastasis, especially if the liver feels hard on exam, can be associated with this syndrome as well. Overall, understanding these interconnected mechanisms helps us identify and manage the underlying causes of diarrhea in these patients. Let's go through the workup step by step. First, an upper GI endoscopy was performed, which revealed multiple ulcers in the duodenum and some atypical or giant ulcers located in the second part of the duodenum. It's interesting to note that peptic ulcer disease, or PUD, typically affects the first part of the duodenum, so these findings are somewhat unusual. Next, we have the breath test, which came back negative, indicating that there's no active Helicobacter pylori infection, a common cause of ulcers. Similarly, the urease test was negative, supporting this absence of H. pylori. We also checked a series of other labs, including the PTH assay, serum calcium, pancreatic polypeptide, and prolactin levels. These tests help us rule out other potential causes of the ulcers, such as hormonal imbalances or pancreatic issues. Overall, this workup gives us a clearer picture. Most notably, the absence of H. pylori and the atypical location and size of the ulcers, which suggests we might need to look beyond common causes and consider other underlying factors. Let's talk about investigations used in diagnosing Zollinger-Ellison syndrome. One key study is the secretin test. In this test, fasting gastrin levels typically increase dramatically, often more than 10 times, surpassing 1,000 pg/ml. This is a hallmark of ZES. However, it's important to remember that certain conditions can falsely elevate gastrin levels, such as the use of proton pump inhibitors, or PPI, as well as H. pylori infection and gastric outlet obstruction. Next, we look at basal acid output. In ZES, this is usually greater than 15 milliequivalents per hour. When you compare basal acid output to maximal acid output, a ratio greater than 0.6 further supports the diagnosis. For tumor localization, endoscopic ultrasound is a very useful tool. It allows us to identify the tumor, especially in the duodenum, but it can also detect lesions in the pancreas and stomach. Sometimes, tumors can be found in other areas like the mesentery, ovary, or even the heart, which underscores the importance of thorough imaging. Speaking of imaging, endoscopic ultrasound is excellent for locating the primary tumor, while somatostatin scintigraphy is especially helpful for identifying metastatic disease. This combination of tests really helps us get a comprehensive picture of the disease extent, guiding effective treatment. All right, let's talk about the treatment options. The drug of choice here is a PPI, or proton pump inhibitor, which is mainly used to help heal ulcers by reducing stomach acid production. This is often the first step in managing the condition effectively. In addition, we have ING, lanreotide, which is a long-acting form of octreotide. This medication helps control symptoms and can slow down certain tumor activities, making it a valuable part of the treatment plan. When medications aren't enough, surgery becomes an option. Specifically, resection of the affected area is recommended, especially if the tumor or lesion exceeds 1.5 to 2 centimeters. Removing larger lesions surgically can significantly reduce symptoms and prevent potential complications. Overall, the treatment approach combines medication to manage symptoms and promote healing, with surgery reserved for larger or more problematic cases. This comprehensive strategy aims to optimize patient outcomes and improve quality of life.